listening to Conferences Online Allergy Special Wednesday Evening Edition, brought to you by the American College of Allergy, Asthma, and Immunology. I'm your host, Dr. Jay Portnoy, speaking to you from Children's Mercy Hospitals and Clinics in Kansas City, Missouri. If you'd like to find out more about Conferences Online Allergy or the American College of Allergy, Asthma, and Immunology, check out our website at www.acai.org. Coming up next, we're going to speak with Kevin Kennedy, the director of a novel environmental health program at Children's Mercy Hospitals and Clinics in Kansas City. We're now fortunate to be joined by Kevin Kennedy. Kevin Kennedy is the Director for Environmental Health at Children's Mercy Hospitals and Clinics in Kansas City. Kevin, it says that you're in the allergy conference room. Is that true?
That's true.
So you're still downtown at Children's Mercy Hospital?
I am. I had a class earlier this evening, so I went ahead and used my time to stay local.
Oh, so you just hung around. Wow. Well, we really appreciate your willingness to spend this time with us tonight. We're losing people now. It's getting a little bit late, but I fully expect that people on the Pacific Coast will probably join us. I'm going to go ahead and, do you have any slides or things you want to present?
I do. I have a PowerPoint I can bring up.
Okay, I'm going to switch so that you're now the presenter. All you have to do is click OK. And there we go. And we can see your screen now.
Everybody see that all right?
I see it just perfectly. So take it away, Kevin. What would you like to, you're going to talk to us about environmental health assessment for asthma and allergy patients. So take it away, Kevin.
Well, I thought I would use this evening to talk a little bit about our home assessment program and just walk through the process we go through a little bit for home assessments, and then we could talk about some of the issues that come up as you go into homes and some of the complications and things that can exacerbate situations or symptoms. Thought I'd better throw in a disclosure just to let everybody know I don't have any conflicts of interest. I'm going to close my conference screen at the side there so that you can all see a little better. I always like to put in a little bit of information about asthma prevalence. No doubt you're all well aware of these statistics, but it just shows the significance of this disease across the country. It really is reached epidemic proportions, and I might put in a plug for we ought to have an epidemic effort by public health to try to not only help manage asthma across the country and help not only the patients but health plans, but also to try to put more dollars into research. Considering how many dollars are spent here, over the years, the asthma guidelines have put greater and greater emphasis on the environment and on the importance of evaluating environments. This 2007 guidelines has put even more emphasis on assessment and monitoring of both patients and home education. The research has clearly shown is a key component, education and case management, and then control of the environment itself and comorbid conditions, and then the need to have effective pharmacologic therapy and asthma management plans for when to use that therapy. The guidelines emphasize the importance of evaluating exposure in patients and knowing what they're sensitive to, and recognizing that if you know what they're sensitive to, you can expect that those are things that are going to probably increase asthma symptoms and exacerbate asthma flare-ups and potentially asthma attacks. And so the guidelines further state that for long-term management of asthma, it's essential to identify those exposures and work to reduce those exposures. So that means you've got to have an assessment process to work with families to identify exposures and then work on a multifaceted, comprehensive approach for reducing those exposures. The research over the last several years has clearly shown that single steps or individual types of interventions by themselves are not effective. The guidelines offer important information to clinicians about the important role of allergens and understanding indoor allergens and how they can affect a patient, what the patient's medical history is, and identifying those allergen exposures, doing some kind of testing to determine what they're sensitive to, and the importance of the significance of those positive tests and in context to the patient's greater medical history. And then for patients who have any level of asthma, we really should be focusing on reducing all possible exposure if we can, and looking for ways to avoid exposure to allergens. But also, the guidelines talk more specifically this time about other kinds of irritants and chemical exposures, specifically environmental tobacco smoke, combined with the Institute of Medicine report that showed that there's, at this point, pretty clear evidence of a causative relationship between dust mite exposure and asthma development, and environmental tobacco smoke in very young children. There seems to be a very close linkage to the cause or development of asthma. The guidelines recommend multifaceted educational programs, and there's lots of research now to show the importance of educating families, to empower them to make their own decisions about how to intervene in their own environments, that they must be involved in that intervention process and change behaviors in order to reduce the allergens and therefore reduce exposure, and that there's a need for further research to evaluate the cost effectiveness of these programs. Well, we at Children's Mercy have been involved in home assessments for about the last 12 years. And we've tried very hard to implement these different pieces of the effective home assessment program. But at the same time, the EPA has recognized in the last 5 years the importance of environmental control in asthma management, and has done a phenomenal job with their annual National Environmental Leadership Awards for asthma management, recognizing both providers and health plans that have innovative approaches to paying for home visit programs, to support in-home education on asthma and on home contaminants and home triggers and how to reduce those. And at the same time, the health plans have shown through their own data that these kind of interventions, home visits with multifaceted interventions, and education and case management for the families, pays for itself. And these are two examples of reports. One on the left from the EPA is specifically to help physicians and health plans implement a home visit program, and offers specific data to show a cost comparison between the cost of the home visit program and the benefit in the reduced health utilization by the family and the reduced lost work days and the other things that benefit the whole family. On the right from the Asthma Regional Council is a business case report that goes very specifically through the same kind of economic information. Both of these documents validate the value of a home visit program for patients who have asthma. When we go to homes to investigate, there are a couple important things. We only go to homes where families are having symptoms that don't respond to the regular treatments. So we're part of the solution we try to provide to families. We go to homes of families that have symptoms that might be responding to the treatment, but it's requiring the treatment to be continued, recognizing that we want to make sure that they are complying with their action plan, for example, that they are complying with the treatment and therapy that's been recommended for that particular family. We also have a very active schools program and go to any kind of environment where children are housed when a pattern of symptoms has been identified and they've asked us to come and investigate what's going on. The key steps to our home assessment process, and one that we have found to be effective. Generally, we get phone calls. We get about 300 to 400 phone calls a year. We have to go through a bit of a triage process with those. At the same time, that's an education process. Then, once we go through that process, we're looking at gathering health and environmental history. There's a referral and communication step. We are using that information to generate a hypothesis. The hypothesis drives a part of the assessment, and a key component of the assessment is the in-home education. We may need to do environmental measurement and sampling. That's followed up with a report, and that report might include issues and actions, and then continued follow-up and case management of the family. And we'll kind of go through these individual steps here. For our initial contact with families, we use this Healthy Home Questionnaire. It's an effective tool for gathering some basic information from the families to make a determination about whether the home is actually related to the symptoms that they believe are being exacerbated by their home. There are 3 sections here. There's a health symptoms section, a home assessment section, and indoor air quality section. The more yes answers in any one or individual section of the Healthy Home Questionnaire, the more likely the 3 different components are interconnected in some way, and that kind of guides whether we're going to pursue further the idea of a home assessment. That's also guided by the level of understanding of the family and what they're telling us about their illness, and have they seen a physician. We want to make sure that if they do call us directly that they've taken the time to talk to their physician. If they haven't, we're going to refer them back to their physician. We may have physicians refer us, and in those cases we'll use this referral form and ask them to specifically tell us a little bit about the patient, provide us a diagnosis if they can. That diagnosis we're assuming is one that could be potentially affected by environmental exposure. We ask them to answer some criteria questions for justifying the need for an environmental assessment. We give them an opportunity to give us more comments, that relevant information that they think would be of value. And then on this form can be then faxed directly to the health insurance plan, and it gives them the information from the physician. It gives them justification for the home visit and any other information they might want in a contact with us directly. We get a certain percentage of our home visits at this time paid for by health insurance companies. It still takes a little bit of lobbying on our part if we are going to get them to pay for it. Families that do come to Children's Mercy are fortunate that the philosophy of the hospital is to provide service without regard for ability to pay, so oftentimes the fee for the service is negotiated down, but the benefit is, we feel, outweighs the cost of that fee. Through our discussions with the family and gathering information, and based on talking to their primary care physician or their specialist, we summarize the medical history and try to come up with a hypothesis based on what they've told us about their medical history, based on what they've told us about the environmental history of the home. You can see on the bottom of this form that we try to talk about specific education points and verify that we have talked with them about these particular issues, because all of these things are potential environmental irritants in a home, and if we have several of these going on in a home, it helps us to better define the hypothesis before we go out. We use what they tell us about the level of their illness, the severity of their illness, and the severity of the environmental conditions based on what they're telling us to make a determination about whether this is a level 1 or a level 2 assessment. We divide our assessments into 2 levels. A level 1 is a visual assessment only, where we're trying to provide more intensive education and case management. We believe that's going to be sufficient for that family. In some cases, based on what they're telling us about the home environment, it sounds like it would be valuable to do some environmental measuring, collect some environmental samples, and that's what we call a level 2, where it's a more intensive environmental investigation. So for the home visit, once we get to the home, one of the first questions that we ask in that discussion is do they own the home or do they rent? If they do own the home, obviously there's no concern. They've given us their permission to be there. But there is the possibility with rental property that the landlord might not want us to visit the property. In most states, most ordinances in counties involving landlord-tenants or leases, an occupant of a property can have anybody come into the property as long as they're not doing anything to damage the property. In our case, we're just taking measurements out of the air. We're not actually taking chunks of a wall or something or breaking into walls to try to make determinations, or at least we haven't yet. We also encourage families, once we've given them a report, that they give that report to their landlord, especially if we've identified some specific issues that really are the responsibility of the landlord to try to take care of. There are 4 basic factors that we always take into consideration when we perform our home assessments. As I've been talking about, the health and medical history of the patient is critical. The sources of environmental hazards that both they may have mentioned or that we may identify. We're trying to identify those specific environmental hazards, educate the family about what they are and how they can get rid of those. But at the same time, we're trying to understand the pathways of exposure in their home. So we're looking at the house as a system, and how does the air movement or the heat that's going, the heat sources in the house, how is that driving air movement through the house? What are the moisture sources? And how are all of those interplaying to create or exacerbate the sources of environmental hazards? And then how does that ventilation system enhance or inhibit the pathways of exposure by the pressure differentials or the air movement itself? There are a wide variety of visual assessment tools out there now. Because there are now close to 450 to, it might be up to 600 at this point. Last I heard it was just under 500. I think there might be this year getting close to 600 asthma coalitions across the country. A lot of them are very actively involved in home visits. There's a variety of visual assessment tools. These are just some of the examples that are out there, and I have all of those and could provide any of them to anybody who's interested. This is one that the EPA developed. I think it was in 2005. It's about a 12-page document. It is a pretty good basic document for that level 1 kind of assessment when you're doing an intensive interactive education with the family in the home, doing a walk through the home and talking about specific potential sources in the home, talking about specific asthma triggers and behaviors of the family that might be impacting health. There's another example of a visual assessment tool. This is from the Community Environmental Health Resource Center. But this is a good example of some of the areas that we're going to look at. Our philosophy is that an assessment has to be comprehensive. We can't just focus on classic allergens. We try to look at the whole house and look at all the potential chemical irritants as well as other kinds